Congenital disorders of relevance to the anaesthetist. Congenital conditions affecting the airway. Introduction. Many congenital syndromes present challenges with airway management due to difficulties with maintaining a mask airway, mask ventilation and intubation. Anatomical features associated with difficult airway management in children includes macroglossia, micro or retrognathia, limited mouth opening, mid-face hypoplasia, cervical spine instability, limited motion of the cervical spine, and abnormal soft tissue airway structures, and other facial abnormalities impairing mask fit. It is important to perform comprehensive preoperative evaluation of the child's airway in order to plan management. Features possibly indicating airway compromise includes poor feeding, apnea, airway obstruction, respiratory failure, subcostal or intercostal muscle recession, tracheal tuck, use of accessory muscles, and pulmonary hypertension. Examination should seek the features above and make an assessment of jaw protrusion, Mallampati score, mouth opening, dentition, nasal patency, neck abnormalities, and restriction of movement. However, formal airway assessment is often difficult in uncooperative children. Review previous anesthetic records for details of mask ventilation, CL grade, special techniques used during airway management, and any difficulties experienced. All the conditions described here may be associated with outward direct laryngoscopy. Alternative means of glottic visualization should be immediately available, such as fiber optic or video laryngoscopy, and airway rescue devices such as supraglottic airway devices. It is essential that the anaesthetist has an assistant when managing a child with difficult airway. It is particularly important to address this in settings where the anaesthetist usually operates alone without a specifically trained anesthetic assistant. Conditions associated with difficult airway includes Down syndrome, cleft lip or cleft palate, Pierre-Robin sequence, Golden Haar syndrome, Treacher-Collins syndrome, syndromic cranial synostosis, mucopolysaccharidosis, Beckwith-Wiedemann syndrome, and Klippel-Feil syndrome. Regarding Down syndrome, kindly refer to the video on Down syndrome. Cleft lip and or cleft palate. This is a relatively common abnormality. Cleft lip or cleft palate may be an isolated finding or may be associated with syndromes. This condition may contribute to difficult laryngoscopy, particularly if associated with micrognathia or other craniofacial abnormalities. A more lateral approach to direct laryngoscopy may be helpful. Following palate repair, the tongue may cause airway obstruction. Hence, these children should be extubated when they are fully awake and observe closely for impending airway obstruction. Pierre-Robin sequence. Features of this syndrome includes micrognathia, posterior displacement of the tongue, cleft palate, and association with congenital heart disease such as VSD, PDA, and ASD. Upper airway obstruction often occurs after induction of anesthesia, necessitating the use of airway adjuncts or LMA to maintain the airway. Direct laryngoscopy can be very difficult. With age and growth, the mandible of these children usually become easier to manage. Pierre-Robin sequence often occurs in otherwise normal children, but can occur as a feature of multiple malformation syndrome. Golden Haar syndrome. This is associated with asymmetrical hypoplasia of malar, maxillary, and mandible, i.e. hemifacial microsomia. Epibulbar dermoids, congenital heart disease, such as VSD or TOF, and cervical vertebral defects. Mask ventilation is challenging due to poor mask seal. Intubation may be difficult due to mandibular hypoplasia, limited mouth opening, right-sided hemifacial microsomia, and short immobile neck. Facial symmetry may worsen as the child grows, increasing difficulties associated with airway management. Next is Treacher-Collins syndrome. This is characterized by bilateral malar, maxillary, and mandibular hypoplasia, small mouth, TMJ abnormalities, down-slanting palpebral fissures, defect of lower eyelid and malformation of external ear, and association with cleft palate and cardiac abnormalities. Direct laryngoscopy and intubation may be very difficult and may become more so with increasing age. Syndromic craniosynostosis. Commonest syndromes includes Apert, Crozen, Pfeiffer and Sercher-Chotzen. These conditions are characterized by prematurely fused skull bone sutures and involvement of the facial skeleton, leading to upper airway obstruction and raised ICP. 50% have OSA. There is increased risk of airway obstruction on induction of anesthesia, difficult mask ventilation, and perioperative respiratory complications. Difficult laryngoscopy is unusual. Mucopolysaccharidosis, MPS, are lysosomal storage disorders caused by enzyme defects, leading to accumulation of glycosaminoglycans in cellular lysosomes throughout the body. This results in coarse facial features, airway abnormalities, organomegaly, cardiac dysfunction, joint and bone deformities, visual, auditory, and intellectual impairment. Deposition in the soft tissues of the mouth and pharynx leads to macroglossia, thickened oropharyngeal and nasal mucosae, adenoidal and tonsillar hypertrophy, copious secretions, and narrow trachea. Deposition in joints and bones leads to short, immobile, and potentially unstable neck and reduced TMJ movement. Various subtypes exist. All of the above can combine to make airway management and intubation extremely difficult. Most challenging are those with Hurler's and Hunter syndromes. These conditions are progressive and lethal. Natural history of airway disease may be altered by successful bone marrow transplantation. Spontaneous ventilation should be maintained until the airway has been secured. However, airway obstruction can occur early during inhalational induction. Placement of an LMA in these patients may be difficult, requiring several attempts, and be only partially effective or ineffective. While managing the airway, it is important to maintain the neck in a neutral position, as there may be cervical spine involvement, such as in Morquio syndrome. Spinal cord compression can occur due to thickening of the dura and due to odontoid hypoplasia. Preoperative MRI scans without anesthesia of the spinal cord may be appropriate in selected individuals. Beckwith-Wiedemann syndrome. Features includes macrosomia, visceromegaly, including cardiomegaly, macroglossia, omphalocele, and hypoglycemia. Macroglossia can cause upper airway obstruction. Chronic airway obstruction may cause cor pulmonale. Macroglossia complicates airway management. Partial glossectomy is occasionally required. Klippel-Feil syndrome. This is due to failure of cervical vertebral segmentation during fetal development. Features includes short neck rigidity due to fusion of cervical vertebrae, most commonly C2 and C3, and low hairline. Direct laryngoscopy and intubation may be very difficult. Next are conditions associated with congenital heart disease, which includes Down syndrome, Turner syndrome, Noonan syndrome, Church association, Factorial association, and DeGeorge syndrome. Cardiac disease is a frequent association of a number of congenital abnormalities. Careful evaluation of the cardiovascular system should be undertaken when other major abnormalities are present. Regarding Down syndrome, refer to the video on Down syndrome. Turner syndrome. These are females with short stature, short, webbed neck, ovarian dysgenesis, and XO karyotype. Micrognathia leads to airway management difficulties. Turner syndrome is associated with bicuspid aortic valve 30%, aortic coarctation 10%, renal abnormalities 50%, caution with renally excreted drugs. Noonan syndrome has phenotypic similarities to Turner syndrome, including short stature, short or webbed neck. Cardiac defects associated with Noonan syndrome includes pulmonary valve stenosis, hypertrophic cardiomyopathy, AST, TOF, aortic coarctation, mitral valve abnormalities, and AV canal defects. Other associations includes micrognathia, hydronephrosis, and platelet dysfunction. Pre-op assessment should focus on airway assessment, cardiac assessment, and renal assessment. The Church Association stands for C for ocular coloboma, H for heart defects, such as TOF, PDA, double outlet right ventricle, VSD, ASD, and right-sided aortic arch. A for choanal atresia, R for retardation in growth and development, G for genital abnormalities, and E for ear anomalies or deafness. Tailor anesthetic plan according to individual lesions present. The vector or vectorial association stands for V, vertebral anomalies, A, anal atresia, C, cardiac defects, T and E, tracheoesophageal fistula, R for renal anomalies, and radial dysplasia. Tailor anesthetic plan according to individual lesions present. DiGeorge syndrome involves chromosomal 22 microdeletions leading to failure of third and fourth embryological pharyngeal pouches to differentiate into thymus and parathyroid glands. There is hypoplasia or aplasia of the thymus, leading to deficiencies in T-cell mediated immunity and susceptibility to fungal and viral infections. Blood products should be irradiated to prevent graft versus host reaction. Meticulous sterile technique is important when caring for these children. Hypoplasia or absence of parathyroids leads to severe hypocalcemia with tetany and seizures in early infancy. Serum calcium should be checked preoperatively. Cardiac defects are present in 85%. DiGeorge syndrome is the second most common cause of congenital heart disease. Associated cardiac defects include VSD, right aortic arch, TOF, aberrant left subclavian artery, truncus arteriosus, double aortic arch, and interrupted aortic arch. Other features include micrognathia, short trachea, cleft palate, and choanal atresia. Other congenital conditions of importance to anesthetists: neuromuscular disease. These conditions can be divided into the following categories: myasthenic syndromes, involving abnormalities in the release or action of acetylcholine; channelopathies, involving abnormalities in postsynaptic membrane or the sarcoplasmic reticulum; dystrophies or myotonias. This involves abnormalities in the myofibrils; and mitochondrial myopathies, whereby there are abnormalities in the mitochondria. Duchenne's muscular dystrophy. This is seen in 1 in 3,500 live male births. This is an X-linked recessive disorder. There is rapidly progressive weakness, presenting between 2 to 5 years of age. The child is usually wheelchair-bound by age of 12. Respiratory weakness leads to respiratory failure. Cardiac failure is due to myocardial degeneration. Death usually occurs by the 3rd or 4th decade. There is risk of anesthesia-induced rhabdomyolysis. There is a weak recommendation that volatile agents should be avoided to avoid this. Avoid saxametonium due to risk of hyperkalemia. Myotonic dystrophies. This is a group of hereditary diseases of skeletal muscle associated with sustained contraction after stimulation. Types include dystrophia myotonica, myotonia congenita, and paramyotonia congenita. Dystrophia myotonica is associated with cardiac conduction defects. Avoid saxametonium, which can induce generalized myotonia. If muscle spasm occurs, lignocaine directly injected into the muscle may prove useful. Kindly refer to Finals SAQ 48 for further information on myotonic dystrophies. Mitochondrial myopathies. This is a heterogeneous group of conditions with a collective incidence of 1 in 4,000. Defects in electron transport or oxidative phosphorylation and tissues that are most metabolically active, such as the nervous system and muscles, are most affected, leading to clinical manifestations. Various types exist, such as Kearns-Sayre syndrome, MILS, MDS, MELAS, MIDD, MNGIE, MERRF, NRAP, and Pearson syndrome. The most severe forms present in the neonatal period with profound weakness, acidosis, liver and renal failure, and substantial neurological impairment. Pre-op workup will depend on the clinical condition, which should include full cardiorespiratory evaluation, including ABG and pulmonary function tests, and appropriate assessment of other organ function, with measurement of electrolytes, glucose, lactate, pyruvate, CK, liver and renal function. The optimal anesthetic technique for this group of conditions remains controversial. Propofol may be best avoided, particularly by infusion. Regarding malignant hyperthermia, 3 conditions with a definitive link with MH includes central core disease, King-Denborough syndrome, and Evans myopathy. Next is inherited metabolic disorders. These conditions are caused by genetic defects, leading to absence or dysfunction of structural proteins or enzymes. Some conditions present significant challenges to anesthesia. Symptoms and signs may be related to accumulation of metabolites proximal to the block enzyme that may be toxic or inappropriately stored within cells, or deficiency of a metabolite downstream of the block enzyme. They are broadly classified into the following categories: disorders of amino acid metabolism, urea cycle disorders, organic acidemias, disorders of carbohydrate metabolism, such as glycogen storage diseases, lysosomal storage disorders, and disorders of fatty acid oxidation. Conditions of particular concern to the anaesthetist includes mucopolysaccharidosis, which has been discussed previously, and organic acidemias. As a general principle, keep children with inherited metabolic disorders well hydrated and avoid hypoglycemia during starvation. Epidermolysis bullosa. This is an inherited group of skin disorders characterized by cleavage at the dermal-epidermal junction, resulting in erosions and blisters from seemingly minor trauma to the skin or mucosa. Three main forms of epidermolysis bullosa includes simplex, lethalis, and dystrophic. The simplex form is usually relatively mild form with rapid healing and little scarring. For lethalis form, this is junctional epidermolysis bullosa, which is a severe form that presents at birth, leading to extensive scarring and death usually before the age of 2 years old. The dystrophic form is a rare but severe form. Lesions are slow to heal, with extensive scarring, resulting in strictures of the mouth, pharynx, larynx, esophagus, limb contractures and fusion of digits. Blistering or strictures of the esophagus and oropharynx can lead to reduced oral intake and malnutrition, leading to growth retardation and anemia. Infections are common. Antibiotic prophylaxis may be necessary. Adrenal suppression can occur due to the use of powerful topical steroids and oral steroids, necessitating perioperative steroid replacement. There is association with dilated cardiomyopathy. Care must be taken to avoid trauma to the skin or mucosa. Frictional shearing forces must be avoided. Allow the patient to position himself or herself if possible. Avoid adhesive tapes on the skin. Use low adherence dressings, such as Mepiform or Mepitel, which are silicone based. If these are unavailable, an unfolded gauze swab smeared with paraffin gel makes a sticky dressing that does not shear the skin. This may be kept in place with a crib bandage. Padding should be applied under an IBP cuff. Children with epidermolysis bullosa must be carefully assessed preoperatively, particularly with reference to the airway. Airway management may be difficult due to oral lesions, limiting mouth opening, and adhesions of the tongue and pharyngeal strictures. Avoid intubation and instrumentation of the airway, or lubricate the ETT and laryngoscope generously, and select an ETT that is at least 0.5 mm smaller than the predicted size. If an LMA is used, ensure that it is well lubricated, and it may be appropriate to select a smaller size. Use a lubricated face mask for inhalational induction, and lubricate gloves or apply paraffin gauze to the mask as well as the face. Oropharyngeal secretions can be cleared with lubricated soft suction catheters under low pressure, avoiding contact with the mucosa. Next is osteogenesis imperfecta. This is an inherited group of disorder of connective tissue, principally involving bones, leading to fragile bones. Two main types includes OI tarda type 1 and congenita type 2. OI congenita is the most severe form and usually presents as stillbirth or proves rapidly fatal. The other form is OI tarda, which presents with pathological fractures, blue sclera, and deafness. Osteoporosis leads to kyphoscoliosis and restrictive lung disease. Fragility of vessels leads to subcutaneous hemorrhage. Dentine deficiency causes caries and fragile teeth. Extreme care must be taken with positioning and moving of the patients. Fractures have been reported from minimal manipulation. including application of BP cuff. Careful laryngoscopy should avoid neck hyperextension and dental damage. IV access can be difficult to maintain due to fragile vessels. OI is associated with abnormal platelet function, which may exacerbate perioperative bleeding. These are my references. Thank you.